got graphs and things, and I want to get that over before we get tired, or you get tired of me. I am a family physician. I practiced in the Charlottesville area for 40 years, and I just had a planned retirement about 2 weeks after the coronavirus thing started. So I spent my last, hi Dick, I spent my last two weeks taking care of people by telephone and by video, and doing primary care. And that whole time I've done primary care. So my perspective is from the primary care doctor. And I also have a lot more time right now, like all of us do, to look into this. And I have a particular interest in getting people tested because it's really hard to get people tested. And so I'm working on that as a side thing. But for the most part, I've gotten to learn about the disease and what it means for me and for my grandkids and for the world going forward. And I've used some tools that have been good, and I've had the opportunity to research and follow up the big picture and the small picture. But I am not proud enough to believe that I know more about the combined knowledge that there is that I see in front of me. And so we're going to give everybody a chance to say something about what you've heard. I have the boxes to put it in, so when I get some information, I know, well, that's a good one and that's a bad one. And so I'm going to try and do that with your questions too. But in order to give us something positive to start with, I'm going to talk about something that sounds negative. And the positive thing is how quickly things are going to get good. The negative thing is that we're going to use the death rates in the United States and in Virginia to look at that. There is a group called the Institute for Health Metrics Evaluation. If you write down those four letters, IMHE, Institute for Health Metric Evaluation, then you'll be able to put those into your computer and
they
go
can't
right.
see us because I didn't do camera.
Who was that? Okay, not for me.
Yeah, we need you. Sorry, whoever that was, we need you to mute unless you were asking a question. And so if you would please mute yourself if you're not already. Thank you. Go ahead.
I didn't know if that was a question there, and I'm sorry to interrupt. Okay, let's start with that, and I'm gonna do the share screen, and that will be this screen right here. See if I can find it. Get the magic here. All right. Tell me if you all can see in front of you a screen of COVID-19 projections. Do you see that?
Yep.
Yep.
Okay. So this is the United States of America, and this is these are deaths per day. And I've been looking at these things every day for since the beginning of March. And what you get is the Institute for Health Metrics Evaluation has done modeling for the United States, for each state, for most of the countries of the world. And they're doing it mostly for this reason right here. They're doing it for determining resources and how many beds are needed, as you see down in the right-hand side, and what our bed shortage would be, how many ICU beds that are needed, and what the ICU shortage would be. Can you see my cursor moving when I do that?
Yes.
Okay, great. So what you see here, this is the curve of increased death rate, how many deaths per day in the United States. And this is a statistical irregularity, but they had predicted a maximum of 3,000 deaths per day, or a probable 3,000 deaths per day, and it got up to 2,600. And that peak was 7 days ago. So we are actually on the downslope of death rate in the country. So many of you have probably heard that or been aware of it, but frankly, the news is a lot about what next bad thing is happening or what's the total number of deaths in the United States. And of course, It's terrible and it's not good. And we still have, as you see here in the right lower corner, a bed shortage in the United States. But things are improving. And so if you take, if we take the current date right now, April 22nd, it's projected there'll be about 2,000 deaths per day. And if you go the next 8 days from now, we're down to 1,000 deaths per day. If you go to the middle of May, I don't know if you can follow this with me, but it's in little tiny print. I've gone to the middle of May and the deaths projected per day are 128. And we go to June 1st, the deaths per day in the country are 18, okay? So in the country, influenza kills on average about 50,000 people per year. So far, COVID is right around that or a little bit more. It depends on, you know, how much we know for sure. But what you see here is that this is falling off quickly as we approach the summertime. And I'm going to change the view of the United States and move it to Virginia. So I'm going to do the same thing and you'll watch this curve change. Somebody tell me, did we see that curve change? Would somebody go on and tell me that?
Yes.
Okay. And then what you see on this curve is you see a gradual up and a gradual come down, remembering that these spikes in here are all kind of, they're deaths. They're real people who have died, but 43 and 5, that difference over about a week is really more of a statistical difference than, oh gosh, things are getting horrible and then they're getting better, because this total number of people is so much smaller. You see, this number is 41 deaths a day in Virginia, and now we're actually back down to 26 deaths per day for Virginia. We'll fall more slowly than the rest of the country has. You've heard about flattening the curve. The concept of flattening the curve means we don't have this really high peak like this, like New York did. But the higher the peak, the faster you fall. The lower the peak, this smooth mound right here is going to fall more slowly. But look, around May 1st, 22 deaths in Virginia. By the middle of May, we're down to 4. And by June 1st, this projects that we will have 0 deaths, which is likely also meaning that there are either no or very few new cases in Virginia. And you'll see here that there's a statement here called containment strategy. Right up here, these are the government mandated social distancing, mass gathering restrictions, non-essential services, initial business closures, staying at home orders, educational facilities. And so this says that containment is still going to go on here, but you and I know that we don't know what's going to happen. We do know that this period has already been determined by Governor Northam. And unless he changes it, we'll have had, let's say, almost 2 weeks of 0 deaths per day in Virginia. And I think there's going to be a lot of comfort with people starting to go back to work. But the question will arise, and we'll get to it later. What about face masks? What about gloves? What kind of, what size of gatherings are we going to have? So if you would all unmute, and Jennifer, if you would let people ask questions about what I've just talked about, then we'll move on to some specifics about the disease itself and about the individual people's questions about it.
Okay, all right.
Okay, so I have unmuted the folks that I muted. So if you unmuted muted yourself, I think you need to. So again, we've got a lot of folks. We've got about 35 people on. So if you have a specific question for Dr. Macfarlan right this second, could you kind of wave at me, because I'm just going to have to scroll through the screen.
Mm-hmm.
This is just specifically about what you're seeing in front of you, and whether or not you understood what I said, and if you need any clarification, because we're going to have a lot more specifically about the disease.
All righty. Pleasure. Hope you're surviving in this craziness.
Okay, anybody have a question? And again, if you are talking to someone in the background, we ask that you mute yourself.
Bye.
I have a question. As far
Okay, go
as
ahead.
outside temperature that
Yes.
we're experiencing right now, the fact that going up, does that have anything to do with the number of deaths lessening? Is there a relationship between temperature and death?
Absolutely, there is a relationship, and we don't know why for sure. So I'll tell you two things. The COVID virus, which is a messenger RNA virus, it's just a very small piece of RNA is the thing that codes along with DNA to carry dies at about 160 degrees temperature. So if you heat something in the oven or you put it in the microwave for a while and you get 160 degrees, you killed the virus. Now, the reason I say we know that heat, general, external, natural heat probably will reduce this is because it happens with all other viruses. It happens with influenza. Influenza does not stay around in the summertime. And I dare say it is, as a physician in practice for 40 years, I haven't seen a case of influenza past the middle of May in the United States. It's not that it's not there at all. It's just that almost all viruses diminish in the summertime. And we have no reason to believe that that's not a major component of what's happening here.
Great. Jean, I think you have a question. You've got your hand up. So Jean Foss.
Yes. My question is, I'm concerned that those of us who have been very careful about being self-contained and quarantined, how do we know we've got any immunity at all? Because it seems like we have to come in contact with it a little bit in order to be immune. Does that have anything to do with this?
That's a great question. How do we know if we have any immunity at all? And let me just take that as a chance to put this one away.
So hang on, Andy. Hang on. Okay, Andy, you're good to go.
Good, thank you. I will answer that question about how do we know if we're immune, and that has to do with testing, and testing has to do with knowing whether you have the disease or not. And so let's step back to an individual patient. And you know, I thought about using people's names because it would make it more personal, but I'm so used to not using names in situations like this. I'm just gonna tell this person, thank you for the question, and all of the people that I have questions from so far. This is a 73-year-old female who has bronchiectasis and atrial fibrillation. Bronchiectasis is a chronic lung disease. When you get a bronchial infection, it gets worse than usual because the bronchial tubes are dilated. And atrial fibrillation is where you have a fluttering of your heart that flares up and makes your heart beat too fast and the blood flow not quite as well. So two risk factors. Number one, chronic lung disease, and number two, chronic heart disease. They're 73 years old. That's the biggest risk factor out of all these. It's a bigger risk factor than bronchiectasis or atrial fibrillation. So she did identify herself as one of the vulnerable. The other big risk factor here that she's not is males are more likely. They're 65% versus 45% to get COVID. And that seems to be a national and international thing. This person works part-time with the public, but has been staying at home as we have been directed to. And so the question is, at what point is it safe for this person to come back out into public? Okay, so let's define a couple things. Let's say safe means it's virtually impossible for you to get coronavirus. That would be, you know, nobody never, you never know, but coming back in public, we still have in our cul-de-sac, for example, a sit around once a week where everybody in their, you know, 2 pair or 1 pair are at least 8 feet apart in a giant circle, and we have a conversation for an hour. Now, if I'm downwind from somebody who sneezes, I'm exposed. So the relative risk is very small. It's in free-floating wind. Nobody is wearing masks right now, but nobody is ill. So, and almost everybody is 65 or over. I'm just about 66, so I'm in the category of the higher risk. And so what level of risk do each one of us want to receive? And then another big question is, what level of risk is the government itself going to allow us to have? So right now, we aren't breaking any quarantine rules. We got the small group, less than 10. We've got more than 6 feet in between us. But is there a tiny risk that if somebody sneezes, has COVID, and they are not sick, that they will spread the disease? It is very rare for a person who is asymptomatic to spread the disease without being in very close contact with somebody else, because the viral load gradually increases the first 4 days, and it usually takes from the time the disease inhabits the individual until they're symptomatic. That usually takes 4 days, and this is on average. It may be as short as 2 and as long as 9, but on average it's 4 days, and only 2 of those days can they be transferable. So yes, you can be infected by somebody who is about to show up with COVID but don't have it yet. But it's a small number of people with a small chance. And most of those people you are not going to be in contact with. So the problem is you never know. And the things that we've been asked to do when we go to the grocery store or have contact that we are not expecting, in terms of wearing a mask, wearing gloves, keeping your distance, are all very appropriate right now. I think it's going to be safe to interact with neighbors without known disease, and particularly those people who have been quarantining well, i.e. our mature neighbors. I think that's going to be pretty darn safe, as you saw from that initial picture, the beginning of June and maybe even the end of May, because the disease isn't going to be spreading anymore and people are dying less and less and less. So that's the answer to the when can you interact. The point with when we return to work, I think is going to be best determined by, it's going to be determined by the governor and the United States. Our governor is particularly going to determine when we go to work, because it has been determined that's a state individuated decision. And President Trump has turned that over to the heads of the states. So my expectation is that there's a chance that we will be quarantined slightly less than is already predicted, because people will see that, hey, these deaths are going away. And then that raises the question about what's going to happen afterwards, and what types of things are we going to need to keep from getting a small level of disease in the population that's suddenly going to cause an explosion. And what will do that will primarily be testing. So does anybody have any questions about what we just talked about going back into public? And then I'll talk about testing and knowing, do you have it? Did you have it? And what can you do with that information?
Okay, and I'm going to look for hands to be raised, and then if you could, you'll need to get that, you'll have to get out of that screen that you've got up. I think if you just exit out, it will go away, because we're still seeing a screen.
Me?
Yeah.
Okay.
Yep, so let me look for hands as I flip through the crowd. Jean, your hand is still up. Is that accurate? No? Sorry, let me unmute folks for a second.
Okay.
One moment, please. All right, I'm gonna unmute everybody. So
how about that? Can you see me?
I can still see your screen. It's the one that you had on earlier this morning. It was like the email that I sent you.
It's the test.
It's I, as in I, me,
yeah.
HME.
Okay.
And it stands for Institute for Health Metrics Evaluation.
And the other question is, in the chart, of course, you don't know who to listen to, because you hear all these things on the news. So in your chart, you show Virginia as going down, yet in the news this morning, they were saying how we had gone down for 3 days, and then all of a sudden we had a big rise from Monday to Tuesday.
Great question. And I can easily answer that. So actually, Virginia is not at its predicted peak based on the Institute for Health Metrics Evaluation, because you saw there's a really slow curve to the top of the bump. And we are not there yet. But what you saw from all those peaks that went up and down, we're saying that's a statistical variation. That does not, a day-to-day change does not predict the future, okay? A week-to-week change is a better prediction, and 2 week to 2 week is a better prediction than that. And so what we're talking about is, don't go on the day-by-day media excitement, or gosh, we're saving everybody, only 4 people died today. You saw that it went way up into the 40s and way down into the 10. And you'll hear that, but look at the overall trend. And so what I mean by it's falling, I was going down the slope, and the slope starts down according to the projections in 3 or 4 days from now. And so it's over that next 2 weeks that it will drop off. The slopes for states are different, and Virginia's slope, we had a flatter high level and less peak than the average state. So we're going to be a little bit slower getting better, but the whole United States, according to projections, is not going to have cases in the middle of late June or the beginning of July.
Okay, thank you.
Okay.
Any other questions for the moment? Yes, Tom.
Yes, the CDC put out new guidelines saying that people should be classified in deaths even if they have not been tested for COVID-19. And there's been a lot in the media that has, in the past week, particularly the past few days, artificially inflated the number of deaths in the United States, particularly in the New York, New Jersey area. And what is your take on that, given that the CDC has said classify it as a COVID-19 death, even though the person has not been tested for COVID-19? Right.
And in some cases, they may have been tested, and they were tested negative, and they still classified them as a COVID death. And so let me give you some world statistics on that. In the United States, we've had more than twice as many deaths as any other country in the world. And yet the number infected per million people is about 2,000. Spain, it was about 4,000. Italy, it was about 3,000. And then a place like Russia, let's see, Russia's 300 and India is 14. 14 people infected per million. I don't think so, okay? Mm-hmm. So what's happening is we have some statistical problems here going on, because we really don't have an absolutely clear diagnosis of what COVID is, because they have used several different kinds of testing, and most of all, so far, we've used this polymerase chain reaction test, and that's the RNA testing. We check the RNA of the actual virus in the system. And that also takes about 4 days. If you test everybody right when they come into the hospital, you find that some people can be tested once, negative. Tested 4 days later, again, negative. Tested when they're discharged, and it's positive. So it's not a surprise that some people, they may not find it at all. So yes, some people have it, but do as many people have it who look like they have it and have tested negative? That's a question I can't answer, and we can't answer until we double or triple test people with different types of tests, okay? So let me address just what the 2 main types of tests that we're talking about, because there's one more in the news right now. Let's just say this is the COVID virus, okay? The test that we're doing now is that we're doing an analysis of how many of these pieces of the COVID virus are in the system, all right? And that's the PCR test, or polymerase chain reaction, and that's the one that says, I'm testing the actual RNA in the body. So there has to be a good bit of it in there, all right? Now, the other type of test has to do with this. This is the COVID virus, And this is your body with a lot of immune globulins. These are proteins in the system that are made spontaneously. Some of them reside around, but they're made spontaneously to attack invaders in the system. Sometimes they're made such in a way that the body attacks itself in things like lupus and rheumatoid arthritis and a number of other diseases. But even allergies can be the body attacking itself. But this is an immune globulin. So the immune globulin is made and the body sends a message to the bone marrow, and it makes a lot of this immune globulin, okay? And so it attacks the COVID virus. We can test this easier than we can test this. Probably for 6 weeks now, there's been a test where you can prick your finger, put a drop on a little piece of plastic with some immune modulator testing in it, and it will produce a result of 2 types of immune globulins that are attacking the COVID virus. Immune globulin M, which is the early responder, and immune globulin G, which is the later responder. Those are 2 immune globulins that can be produced in every disease. There's immune globulin M for different types of flu, for different types of bacteria infections, and the M comes early in attacks and the G comes later. Well, it looks like the immune globulin M for COVID really can start showing up at about 2 days and really kicks in at 4 days. And the immune globulin G kicks in later, about 6 to 9 days. But what we know, if we do a finger stick test with accurate, and there are accurate, 90% specific and sensitive, and that's considered an accurate medical test. That's better than you would get on the flu test if you went to your doctor and they put the thing up your nose to test for flu, put it in a little bit of material, they put the drops on the cassette, and in 10 or 15 minutes you say influenza A or influenza B, or test is wrong. 1 in 10 times, maybe 2 in 10 times, that test is wrong, but it's considered a valuable medical test. We have the same accuracy now in these tests that are available, but are not being used. The primary care doctors are either sitting and talking to you on the phone or on the TV like this, or they're sitting there not doing as much because you're not going to them for your usual visits. And they're trying to keep people out of the office so the healthcare providers won't get sick. So I know that sounds odd, but there are very few visits actually to the office to evaluate people. And many people are either sent to be tested somewhere or sent to the emergency room or if they're very sick. And some people do come into the office. Those tests right now are predominantly the PCR test if the virus is in the system. And for that, you have to get some sputum, you have to get some saliva, you have to put a swab up the nose, and you have to send it off. And if you're really lucky, you'll get it in 2 days, and sometimes it takes longer than that. The University of Virginia has created their own test of that. Many people, many different large institutions have tests like that that have created a similar one, and they're all pretty darn accurate. But very new information coming out of evaluations from China say that if you do this antibody testing, the IgG, IgM, and see, is that in the blood or not, a combination of doing that testing versus the PCR testing may be at least equal or even better. So some of the things that you're hearing in the news about, hey, gosh, you know, all these people are producing the IgG, IgM testing, and we don't know how accurate they are. That's because only 3 or 4 have been FDA approved, but they have been accurate in China when they were done there. So, so then my answer, and it looks like the people who have done it across the world, is testing either with the PCR test, is it COVID, or immune globulin test. Now, in my mind, the immune globulin test has 3 advantages. Number 1, if it's just IgM, that you know it's a new case and that they're either going to get worse or there's more to come. If it's IgM and IgG, both of those, the early and the late one, then you know that the system is going to be still going on. You know, this battle is still going on, and you're probably still contagious. If you have no IgM, the IgM has gone up and come back down, and the IgG has gone up, and so 0 IgM, and you have IgG. Remember, this is all out of a finger stick. That takes 10 minutes. Then what you know is you're most likely immune, 99% likely to be immune, and you're not just immune. You can go to work. You can go out to the grocery store not worried about stuff, and we can get your blood and take your blood and get some of these immune globulins. And that has been shown in China and in a few places in the United States, that for people with really advanced disease, giving that immune globulin IV, whether they're in the hospital or in the intensive care unit, has been shown to be effective treatment. So I think what is coming, you will hear more and see more about it, is a wide array of testing, because we need to not only know who has IgM and IgG, but we need to trace the contacts of those people and see if those people are tested or should be tested. And I presented something to the health department and to UVA where I thought we could get the primary care doctors to all join in and do testing in their own places. And we could set up a system that was supervised by the health department or UVA or whoever else, and anybody could get tested, starting with healthcare providers, and then of course patients, and then people who are asymptomatic and just want or need to know. And I think in the end, many, many, many more people will be tested, even when you're not sick, because it will be valuable for you to know if you have had that immune globulin or not. Questions about that?
All right, hang on. Let me unmute everyone. 1 second. I think, I know you're not Marjorie, but Mr. Brennan, let me unmute you all. 1 second.
Tell them you're Jack.
Yeah, Jack. The thing is here with as far as, thank you for your input, but how did your suggestions, how are they accepted by the powers to be? Because we don't know where to go.
Yes. Well, I'll answer that. I'll answer the question and then I'll deal with a case about it, okay? And so we have some really remarkable people at the University of Virginia who are involved and in charge of the COVID clinic. And right now they're the tertiary care center in the middle of the state, and what they're dealing with is sick people. And so the focus is on sick people. And in fact, any of you who have tried to get tested know that if you're not sick or not sick in a certain way, it's hard to get a test right now. And so that's a lessening a little bit, but for the most part, the people at UVA have been focused on dealing with the situation right in front of them. And they know that this is coming, but they're saying, well, we have a relationship with the health department. And when the health department says, let's get going on this, the health department is going on this. They're evaluating those tests. They're trying to figure out which ones are the best one. And Norm Oliver, who lives here in the city and used to be chairman of the Department of Family Medicine, he really is on top of this stuff. But there are so many things coming at them to be concerned about right now. And we're just now getting into we're not quite so worried about how do we keep people from contact with each other when that, of course, is the most important thing. The emphasis has been on what should be the most important thing.
Oh, man.
We're getting a voice back. We're getting laughter in the background. I don't know if everybody's doing it.
So let me do another question here, and
My doc right now.
a little less of a question as a statement. A week ago, I started to feel feverish and short of breath. My doctor sent me to UVA ER to be tested for COVID-19 and influenza. Both tests were negative. Okay, so we had a teaching point. What are the current? What's the current likelihood that she does not have influenza early in the course of it? It's probably 1 in 10, maybe 2 in 10. So she could still have influenza, but have a negative test. It's probably about the same for COVID right now. But in the meantime, the symptoms have been exactly what we've been hearing about. I'm recovering, but still weak. What do we know about the tests being used by UVA? Is it possible to get a false negative? Absolutely. Every single test that we have gives a possibility of giving a false negative. And that's why, with regards to the question earlier, that's why we are classifying some very characteristic clinical pictures of what this disease looks like as COVID. The tests from UVA, though, are accurate as we determine them to generally be accurate in the medical setting. Is there another respiratory virus making the rounds right now? It's late for influenza. It's not very likely to be influenza. But remember, there's a lot more influenza every year than there has been COVID. There are about 80 to 100 million cases of influenza in the United States every year. There's about 50,000 or 500,000 hospitalizations and about 50,000 deaths from influenza. And we just get our flu shot and go on with that. We've sort of taken that for granted that 50,000 people are going to die. We don't track it. We don't look at it. But that is what happens. And a lot of times it's different kinds of influenza. And there are multiple other respiratory illnesses that come in the winter too. Right now, are there respiratory viruses that come in the summertime or the late spring? Yes, there are. Do I know of other cases of exactly this happening? Yeah, people acting like they had the flu or something like the flu, or fatigue, or even gastrointestinal symptoms now for COVID. So I think right now we have to believe, first of all, how sick we are. And number two is believe the test afterwards. So if you're sick, treat yourself as if you have COVID. And that means if things keep getting sicker, you'll be put in the hospital. And that's not a death sentence. That just means that there are levels to which the illness will go that you need to be in the hospital.
Great. Is anybody, if you can put your hand if you have a question. I'm not going to unmute everybody, but I think, yes. Barbara, do you have a question? Barbara Rogers? Hang on, let me unmute you. One moment. Barbara, do you have a question?
Yes. What's the difference between the SARS virus and this COVID? And is this the first time that the COVID has appeared?
Yes, that's a good question. Okay, so every year influenza mutates. And sometimes the exact same virus comes around the world again. But there are general categories of influenza, and we'll just say there's influenza A and influenza B. But each year they mutate certain components of their DNA. You've probably heard of H1N2 or H3N2. Those are just influenza A. H1N2 is what we make the flu vaccine to try and kill that virus or keep it from growing in our body by making immune globulins, those things that attack the viruses. And so in the system, we want our body to have those immune globulins floating around all the time. So as soon as, if a flu shot works and we have some immune globulins and we're exposed to the flu and the immune globulin attacks it, that attack is going to tell the body to make a whole bunch more. And so we'll either have a more modest case of flu or no flu at all. And so, Barbara, I know that I started that to address what your final question was, but I haven't gotten to your question. What was it?
Sorry, hang on. Okay, Barbara, go ahead.
So would you say that this COVID has appeared before?
Yes. No, a very good question.
And it just mutated?
So what does that have to do with COVID? What it has to do with COVID is there are coronaviruses. There are about 10 coronaviruses that are commonly known. And 7 of them cause, between 4 and 7 of them cause colds, respiratory illnesses that are mild. We have coronavirus in the United States, and that causes colds year-round, but mostly in the wintertime. There have been 2 major coronavirus attacks where there was a mutation of the coronavirus to make it more deadly. And almost all coronaviruses originally seem to have jumped from animals. And both SARS and MERS, you may have heard both SARS and MERS, those were other coronaviruses that mutated to become more deadly and more contagious, although maybe not quite, the contagiousness wasn't quite as severe as the deadliness in one and the contagiousness in another. But those became worldwide because it was a new virus. And so, yes, the COVID-19 is a new virus, although it is a coronavirus. And this is why we don't have any good knowledge about it as to what takes care of it. I can tell you that we do know that in viruses in general, like influenza, respond, the immune system, you can cause the immune system to respond with things as simple as elderberry or exercise or things like that. Statistically, they will reduce the viral load. And we don't know, however, if things like that apply to coronavirus, because the mechanism that coronavirus ultimately attacks people with is that this thing happens and then it causes a release in the system of a lot of what are called histamines and the body's response to a bad allergy. So if any of you guys have allergy, and I know a few of you and a few of you have, and your eyes get puffy and your nose runs like crazy and you're itching, and at most severe, you start to get hives and you get short of breath. That's the situation that happens to people with the advanced coronavirus that needs the respirators. And those things, that immune reaction is called the immune storm that happens in the body. And that happens between the 9th and 14th day. And sometimes the body just can't get over it. And it knocks the oxygen carrying ability of the blood down. And that's unique about the virus as well. So this bug is new in the way that it seems to hurt people and kill people. That's not the usual way this happens. Let me go to another question right now. What's the lifespan of a single coronavirus? What determines that is your environment. And let's just say the environment is, you get it on your hands from something you touch and you wash your hands. It's gone. You wash your hands well, you have either eliminated most or all of it, and it does need a significant, a certain amount of virus on there. Does a certain temperature kill it? Yes, about 160. The surface exposed to the sun will kill it. I don't know, maybe so, but it'll certainly live less long in the sun and in hot, warm weather. What about a cell phone? The statistics say that it probably can live, not be contagious, can live on glass or plastic for a day. It can live on cardboard for a day and a half. Somebody wrote me a question about what about the newspaper? If you get the newspaper and take it out and read it the same day, is that contagious? And this person was doing something wise, I think, by just leaving it in there for a day and then taking it out after that and reading it the next day. What I can tell you, and this is very encouraging, although you'll see the error in it pretty quickly, I can tell you there is no reported case of coronavirus that has been caused by contact from another entity. In other words, almost all the coronavirus comes from respiratory inhalation of these little tiny bits of water that go into the air when you sneeze. And it can come out 80 to 120 miles an hour. When you breathe, you naturally produce these things. And so when you cough, it comes out. But the little tiny air droplets are what seem to do it. And that's the reason for the 6-foot rule. But when I say nobody has come out with a proven case of transmission by contact, it's very hard to prove transmission by contact. And so somebody says, what about the grocery store? I would think of it like this. Think of that when you go to the grocery store, you should have a mask, you should have gloves. And what you're doing is you've got a really fine, let's just pretend that there's a really fine bit of paint on the material that you're getting at the grocery store. And as soon as you pick up something, and not all of them have that paint on there, but some of it have the paint. As soon as you pick up that, you've contaminated your glove, and you put it in here, you put it in your grocery basket, and it might contaminate other things. We have no strong evidence it could possibly happen. So when you get back to your car, you take off your gloves and you take off your mask and you put on a new gloves and mask. And when you get home, you take your stuff out and you wash off what needs to be washed off, and you take things out of packages that you need out of packages, and then take off your gloves and wash your hands again. So if you don't have gloves and you don't have masks, you can make a mask, and you can just wash your hands more frequently, or use the disinfectant more frequently, and follow the 20-second hand washing. And then how long would it take to decontaminate contaminated packages to become virus-free? I think almost everybody can count on 24 hours. And if you've waited 24 hours, that it is virtually impossible to find in a natural setting. It is virtually impossible to find the virus on things. And you'll see studies where the virus may be found a day or two, or even a little bit more after that. But these are ideal circumstances and perfectly well controlled, and not weather exposure and things like that. So let's go to another thing that's on your mind about the things I read. I just have a couple more things to go over with you. So I know that this has been a lot, but what else has been on your mind, that questions that might have been raised?
All right, I'm going to look for hands. I'm going to scroll through and look for hands because I got missed everybody muted. Give me 2 seconds. Anybody got a hand up?
There you go.
Andy, I will throw, let me get back to you, Mr. Brennan. Andy, I want to throw one to you. I want to kind of sneak this one in. So when the center is able to open, what do you think? And you did touch on this a little at the beginning, and I thought it was great, but maybe a little more. So when the center is able to open, what do you think would make people feel comfortable coming back or coming into our new center and carrying on some of our, able to carry out some of our programs?
I would think hearing that there are no COVID deaths in Virginia happening or ongoing, that nobody is allowed into the center with any history and without being tested. And I will say that, I don't know what, no employee is allowed into the center without being tested, and that all of the employees are wearing, and you might decide at first when people come back, masks are being worn. But there are a number of things that we can do to help people feel safer in terms of protection, keeping a 6-foot distance, not doing the general handshake and hugs and all that stuff that we're used to doing and we want to do. But in order to open earlier and gradually, there's going to be a gradual reduction of the PPE, the type of things that we use to protect ourselves from the virus. I know that was vague, but that's what I would expect to see when people open up. They're still going to require something like that. Do I think colleges are going to open in the fall? Not like we normally see colleges open. I don't think so. I don't think people will be comfortable enough. What's the death rate of 20-year-olds with COVID? For the people who get COVID, who are under 20, it's less than 2 in 10,000. So 10,000 people get COVID under 20 years old, and only 2 of them die. But there are a high percentage of those people who can carry it and transfer it to other people. And the older you get, the higher your chances are of dying. So let me talk about death one more time, because the more mature you are, and the more wonderful learned years that we have behind us, the bigger our risk. And if we're doing it in a statistically conservative fashion, if you take all 60-year-olds, then the death rate is probably some 60 to 70-year-olds. The death rate's probably about between 2 and 5 in 100. If you take all 70 to 80-year-olds, the death rate is probably somewhere between 4% and 8%. And if you take all 80-year-olds, then the death rate is probably about 15%. Now, remember, there are 5 main things that actually cause you to have a bigger risk. Apart from that, high blood pressure, heart disease, lung disease, and being a cancer patient with immune problems and diabetes, those 5 things. And if you take people over 80, you can pretty much guarantee they got 1 or 2 of those. And that increases your chance for death. So you can see it is age, but it's not just age. It's also the likelihood that you have other secondary diseases. And the highest risk is an elderly person who already has established heart disease, because it has been shown that the coronavirus increases the chance for coronary artery disease to get worse, but it also causes an infection of the muscle of the heart and makes the muscle of the heart not beat as well too. So that can cause some longer term effects.
Okay, Mr. Brennan, you had a question. Go ahead.
I do. Doctor, how is the hospital processing people coming in and they have medical directives?
Wonderful question. So I was hoping we'd get to that too, because I think this is important for all of us. But it's especially important for those of us who are, closer to death than birth. And I do Medicare evaluations on people, and that's part, you're questioning about advanced directives is what every individual is asked to do each year. And sometimes it's just, do you have some kind of advanced directive in your life already that you've done? And sometimes it's, hey, you're a bigger risk, and what are you thinking about? So I have a dear partner, Tim Short, who worked with me for almost 23 years, who went into hospice medicine, and then he's in palliative care now at the University of Virginia. And he has put together a course on advanced directives with COVID, and he shared some of his thoughts with me. And I think, to me, the most important thing he said is that the main decision isn't the medical system issue, like what are the limits of care that you would set. The main decision is establishing the values and the hopes which guide the setting of those limits, and talking about what your personal values are, what your faith is, what's important to you in life, what it would be like for you to live disabled, what types of things are going to be the determinants of your limit setting, instead of just saying, hey, do you want to be put on a respirator? Okay. So it shifts the limiting setting of a decision from a risk-benefit analysis, like we do in medicine all the time, to decisions that are decisions of love and honoring a family and honoring the people who are alive, and the things that I believe that you guys and everybody else want. You want to be able to have a say in what happens at the end of life. And so having a conversation like this can be not morbid. It can be warm. It can be friendly. It can be a conversation about love. Hey, you guys, I know y'all aren't too worried about COVID. I'm 70 now. If I get it, I got a 1 in 20 chance of dying. If I got a little heart disease along there too, I, have a higher chance, maybe 1 in 10 chance of dying. And I'd like to talk about that before I get to the hospital when I'm feeling bad. And I'd like to talk about it when I get to the hospital and I can still talk. And so having the conversation with the significant others in your family about things like that is never a bad idea, but it's particularly valuable now for us, and it's particularly valuable to our kids who come into the thing of, and the doctors, of course, who say, we're going to do everything we can to save your life. Well, what does it look like statistically that your life would look like if you got saved at this point or this point or this point? And that can all be done as you move along. What what is stable is what your values are in terms of what you want out of life, what you want to be able to do if you survive. And we can't guarantee any of that, of course, in life, but it's really good to talk about that stuff ahead of time. So we use statistics to give people information about that. And I can tell you that the statistics of once you put somebody on a respirator doesn't kill people. They put people on a respirator who can't breathe without it anymore. But, you know, somewhere between 20 and 50% of people who go on respirators do not come off the respirator alive. So do the respirators save lives? We think so. But are there other things that save lives? We're looking and evaluating different medicines. And, you know, I can tell you that if you do get COVID, I would talk to your primary care doctor about the possibility of using hydroxychloroquine or azithromycin or colchicine, these things that have been partially evaluated and not fully evaluated, but they're generally really safe, and they can reduce the chance of progression or reduce the amount of virus that you have in your system. Do they actually save lives? We aren't sure yet. We really don't know for sure, but if you're taking 5 days worth of medicine and it's a medicine that we commonly give for bronchitis, you know, you might consider that. So I think those are very honest questions to ask of your health professionals if you do come down with the disease. And I also do know that, for example, there is an antiviral agent. So I'll use Tamiflu as an example. Tamiflu is pretty good against flu once you get it. And the earlier you get it, the better. And if you're not treated within the first 2 days of getting the flu virus, it probably doesn't do very much for you at all. But if you take the Tamiflu in the first 2 days, it probably shortens the duration of your illness by a day or two. And anybody who's had flu knows that's a 7 to 10 day illness, and 2 days short is not that much better. But for some people it's more than that, and some people it's less. So let's just say, however, though, if you're exposed to influenza and you give the exposed people Tamiflu, there's a very high likelihood it will prevent you from getting influenza, okay? So the point being there, the earlier in the course that you get some of these antiviral medicines, the better. And there is an antiviral medicine that is currently that they only use in Russia and China. And right now, that antiviral medicine has been shown to reduce the chance of getting COVID in a situation where you are exposed to COVID from 44% to less than 5% if you take that medicine once a day. Now, is somebody on the phone with those guys? I hope so, but that's way above my pay grade. And the United States and the FDA has actually been really good so far in giving a lot of emergency approvals before they fully tested everything. And so that's different than usual. But there is an antiviral medicine out there that does prevent people from getting this. And we are using antiviral medicines intravenously for very sick people. We're in the hospital, and that does seem to have some effect as well. Let me see if that's all the questions I have from you guys. And if you have anything else you can think of, let me know.
Okay, I'm going to make sure, those of you that I can't see, I'm going to unmute everybody for a second. So I'm going to give folks who maybe not had a chance to ask questions to maybe have a chance. So let me unmute everybody. All right, is there anybody that does not have their video on that you'll just have to speak up? Sandra, are you?
No. Yeah, I'm here and I can hear everything, but no, at this point, I don't have any questions because Dr. Macfarlan has done a great job of responding to all the questions that are out there.
Hi, Sandra.
Hi, how are you?
Great, let me just, sorry, go ahead.
Is that antiviral that you talked about given intravenous? Is that remdesivir?
No, that's one of the ones that they use intravenously in the United States. The antiviral that I was talking about that they use overseas is it's called umifenavir. But yes, the one that you're talking about is a combination of lopinavir and ritonavir. Yes.
Okay, that act differently than hydroxychloroquine?
Yes, but we do not. It likely kills the virus in a different way. The hydroxychloroquine is an anti-inflammatory, and the hydroxychloroquine, while it decreases the viral count, it may decrease that immune storm that happens that is the agent that kills people. So you see that a number of the drugs that are being tested against this are basically autoimmune medicines. And so medicine to treat rheumatoid arthritis, any of you who've been on the MAB drugs, the drugs that end in MAB, or hydroxychloroquine, or even steroids, although steroids hasn't seemed to work. It looks like there are some autoimmune suppressing drugs that have a benefit in this.
You think Dr. Fauci has come out against hydroxychloroquine and remdesivir? Is that going to dissuade physicians from using it?
Yes, it will. And I think that right now there is evidence from China that both chloroquine and hydroxychloroquine works. Their concern is the resources. Do we have the resources to give it to everybody who has it, and especially in the under 50 crowd where you would need to treat hundreds and hundreds of people to even keep one person out of the hospital. So that's a public health issue. It's different though when you are dealing person to person, and it's also different when we have a substantial supply of these drugs, and people are making millions of them a day as well. So it's very easy for a physician to write a prescription for those things. But I do have to say that in elderly people, to use hydroxychloroquine or chloroquine and azithromycin together, and that's the original French study that showed a dramatic fall in the amount of virus that was shedding after 9 days on that combination. That combination has the possibility of causing prolonged QT syndrome, which is a syndrome of the heartbeat, that goes like this. The QT interval, when it gets prolonged, can cause abnormalities of the heartbeat. And so there's a conceptual concern with this that could be monitored as, if you really need the medicine and you're in the hospital, you just get your heart monitored for the time while you're in there. So I do know that there is a large hesitation to use these medicines that don't have the FDA's full support and approval behind them. But I can tell you that 20% of the prescriptions that we write them for indications currently now in the United States. We write them for indications that they work for, but aren't approved by the FDA. So do I think that's a reason that I wouldn't take it? I'd probably ask my primary care doctor for it.
Great. I have a hand raised from Richard's iPhone. I can't see him, but he's got his hand up. Go ahead, Richard.
Okay, it's actually Susan, but I got quite ill after traveling in early January, and I was diagnosed with acute bronchitis, but terrible cough. Took me 6 weeks to recover from it, from the cough and the extreme fatigue and some other things that were what looked like now as symptoms of the COVID-19.
Yes.
Is there a possibility, because I was traveling in Hawaii and in California where there's high Chinese tourism and whatnot, so what are the possibilities that it might have been that? I would like to get the antibody test, but the NIH hasn't responded to my volunteering, even though they asked for volunteers.
Hi there, how you doing?
Hey, I'm okay, and as you know, I'm a pretty healthy person normally.
You are, and yes, the answer is there was a lot of that going around there, number one. So it could have been whatever strain of virus was. Yes, it could have been COVID. And how important is it for us to know if it was or not? I personally think it's very important, and everybody who has that story would maybe, and there may be people with a lot less severe diseases who have a story like that. Everybody should be tested with the IgG antibody, and you will be able to, almost certainly you will be able to get that test. It's going to be a lot more available. And given the amount of money, like I calculated for us to buy 9,000 IgG IgM tests for this city, when I was thinking about, going about finding a way to do it, would be $135,000. I mean, you get a venture capitalist to write a check for that. That's not 3 days in the ICU. Now, this is not the public health department talking. This is not, somebody from the government. This is a primary care doctor who's looking at the situation and said, we do these kind of tests all the time. Why can't we do them now? And it's because they aren't approved by the FDA, and we may be causing harm if we tell people something that seems like it should be right, and it's not. So I can partially understand this, but what it is, it takes away our judgment. If I get somebody who looks like they have flu and I do the flu test on them, and I say, man, this is flu, I'm gonna put you on some Tamiflu and treat you like you have flu. That's not a bad thing to do. But if I say, gosh, I don't know if this is flu, and I test them and they're positive, they're gonna get the flu treatment, So we use judgment all the time on tests that aren't perfect. But I know that they do have 3 of these now that are approved by the FDA. They will become more available. And so just keep your eyes out, Susan, for when you're going to be able to ask for that test. And I'm keeping track of that through our prior practice. Right now, they're still sending the tests out to either UVA or Centera, I think mostly in this area.
Great, Annie, I think you covered all the questions that were submitted prior, correct? I just wanted to make sure.
Good. Then let me see if there's 1 or 2 more things. The question comes up, how much worse than the flu is this really? And, it looked like at first, about 4% of the people were dying, and then it looked like 2% of the people are dying, and now the overall mortality rate in China was calculated at 1.4%. And if we look at California, who has just reported that they think 200 to 400,000 of their people probably have had COVID, and if you take that number and use that to divide it by the number of people who had COVID, then the mortality rate falls even lower to 0.1% or lower. But it's definitely true that this has a different picture than influenza for the people who die of it. And it's definitely true that it does have a greater mortality rate than influenza. So like I said, we get somewhere between 75 to 100 million cases of influenza every year in this country. And so I think some of what's going to change about COVID is this mindset too. There probably is going to be a cadre of COVID that's hanging along. And what we want is not for it to go to 100 million cases, because it looks like it's maybe worse than flu by a factor of 10. But so what we have tolerated with influenza is 50,000 people dying a year related to the influenza virus. God forbid that we have to tolerate that with COVID. And yet we have not been able to, even with medicines to treat influenza, even with immunizations against it, we have not been able to beat that back. We have just come to a different mindset about it. So understand that, this process, this whole system is going to change. And the most important thing that we can do is live our lives as whole people together with where you are. So I personally have found, and I was hoping we'd have some time to do a couple stories of what you guys have found, but I have found that this has turned our house into a place even better than it was before. There are so many opportunities now that we haven't had because we aren't in a hurry. We have space for each other. If we attend to that and lead with our hearts in the home and, attend to, everything from apologies to reconciliation to gratitude and enjoyment of each other, it's going to make a lifetime difference for us. So we can actually now establish habits in our lives that have even bigger meaning than the virus that is messing up the earth right now. Any other thoughts out there?
Let me unmute everybody that I muted. One moment, please.
They have,
all right.
They've sent me to the website and I've talked to 2 other people and now I'm back to where I started from. So hopefully you can help me.
All right, so I'm not sure who that is, but anyway, I think she's not in our meeting. Anybody else have a question? We can, in a couple more minutes, but I want to make sure. Again, if you just, I really like what Andy just said about, finding kind of a new environment through all this and a better one, hopefully, for most. So if anybody has,
Thank you.
Advertisement.
Thank you.
Look what the center is doing now. Look what a lot of people are doing online. But read those things that come out from the center, just like you read your center newsletter. There are some amazing, astounding, and fun things. And hopefully this has been valuable to you and not depressing and can be encouraging. I really do think it's going away in the summer. I don't know if it's coming back in the fall, but it probably will to some degree. I know people much smarter than me and with more experience than me are dealing with this, and that we kind of have to plan for a worst case scenario because that's what a lot of people are complaining about. We didn't have the plans in order for a worst case scenario. But I think this has been a valuable time for us.
Great. Well, Diane, were you clapping or had your hand up?
Clapping.
Awesome. Yeah. Great. Excellent. Very good. I want to remind folks, thank you, Andy, for that plug for the center. And we do invite folks to go on our website because we're up to about 25 programs a week that we've kind of recreated. So it's been a challenge, but it's been fun and very rewarding for not only me, but I think for the folks that attend them. So go on our webpage because it's on our calendar on the website. And the stuff that we do special every week is coming out in that e-news that you get. And if you don't get our e-news, we invite you to go on to the bottom of our homepage and subscribe to it. And you get everything cool and fun that's happening. So I'd really like to thank Andy and for his time and his research that he did and his preparation. And we really look forward to Andy he's doing a series at the center when we open called The Pathways to Flourishing Health. And he's pretty much outlined that for a year. So we're looking forward to that.